Hello, my name is Ian McCall, and this is one of the consultations in dermatology. Today we're going to talk about the injury that spreads, and the injury is sporotrichosis. It's a deep fungus that's inoculated into the skin, usually from an injury, and the classic is with a rose thorn. But also any rotten wood or even peat moss can do this. This is a deep fungus. It's not a dermatophyte that grows on the surface of the skin. The spores of this organism are inoculated by the thorn or the piece of wood under the skin. And initially, the wound may in fact heal, but probably 3 to 4 weeks later, it starts to erupt. When it does erupt, it looks a little bit like a boil, but unfortunately, it doesn't respond to antibiotics. And it's at that point that the clinician usually starts to wonder what's going on. But there are a few other features of this condition that make it almost unique. And it's one that if you see this feature, it allows you to make the diagnosis. And what is the feature? It's basically lymphatic spread, where the organism travels up the lymphatics and periodically forms another little abscess that erupts onto the surface of the skin. So, let's have a little look now at some of these images of sporotrichosis. This case arose actually in a doctor who was handling peat moss in the garden, and she must have had a small injury to her skin. The organism penetrated, and it didn't really heal at any stage at all. There wasn't a phase where it seemed healed. But then she started to develop a little nodule here and a little nodule here. And gradually it went up her arm. This was taken at the stage where she had had an incisional biopsy into this. Remember, this is a granuloma, so the process is fairly deep in the skin. You may not pick it properly with a punch biopsy. An incisional biopsy is much better to give the pathologist a chance to see it. It's sometimes difficult to see this organism. It's also quite difficult to grow this organism. It's put... Well, that last bit's not true. It will in fact grow. It'll grow in saboros quite well. But it's a temperature-sensitive organism. And we'll come to that later when we're talking a little bit about treatment. You know, when you've got a fairly florid granulomatous reaction like this, you know, what are the differential diagnoses would you have? Well, from an infective point of view, you know, it could be just basically a staph furuncle, some type of staph granuloma. It could be TB or an atypical mycobacterial granuloma where the organism is picked up from a swimming pool. And there are other deep fungal infections that may be responsible, depending on the part of the world where you are. Nocardiosis, actinomycosis, blastomycosis, coccidioidomycosis, and chromoblastomycosis are some of the fancy names that are associated with these. In the old days, even syphilis would have to be considered, and certainly, you know, a thing that's pink like this, or even slightly purplish, you'd have to think of neoplastic things like lymphomas. A solitary lesion would even have you thinking of an SCC, but once you start to get spread up lymphatics like that, it's then that either sporotrichosis or atypical mycobacteria infection come to mind. And rarely, things like pyoderma gangrenosum and Sweet syndrome can occur like this. But we're looking at an organism that's spreading up the lymphatics. And this was just a close-up of it. You can see the different morphologies. Here, there's not much in the way of epidermal involvement. Here, it has in fact broken through the epidermis, and you have little areas of ulceration and pus coming out as well. Now, sometimes it's not quite as gross as this. Here's one in the dorsum of a hand with 2 little lesions here. Again, this one was from a rose thorn, and you can see the rough surface where the granuloma is up, involving the epidermis and penetrating a bit as well. So the organism that causes sporotrichosis is Sporothic schenki. And it, according to Shelley, was named, the organism itself honored the brilliant second-year medical student at Johns Hopkins by the name of Benjamin Schenk. And apparently in 1896, he was not only the first person to recognize sporotrichosis, but also to identify the cause. That Shelley says all this, and he became a gynecologist. God bless him. So this particular organism, how do you think about treating it? Say you've got your case of sporotrichosis. Well, remember, you have to do your incisional biopsy, and you send it for both histology and for culture. And it may take a little while for it to grow, sometimes 2 to 3 weeks, sometimes quicker than that. We'll show you, if it is going to grow, let's show you a culture here. That's a stab culture, and this is the organism growing. I haven't got one of the microscopy of this particular organism. Here's another example of this condition. This time it was in a plumber who, they're exposed to all sorts of dirty environments. And again, this was the initial lesion here. And in fact, sorry, I tell a lie. This was the initial lesion here. And then it started to spread up the lymphatics. And if we look at the other views here, you can see here it's quite rough on the surface here, but if you feel this, there's a lot of induration round about. And this was just a close-up of some of these. Now, the degree of reactivity and how localized the infection is really depends on the person's immune response. If you've got a very active immune response, then you can localize that infection and it may not spread as much. And this is part of what's happened in this particular patient. You can see we've only got 2 lesions here, but they look very chronic lesions. And this is because the infection's been able to be localized by the patient. But with a granuloma, the organism's protected in the center of this granuloma. There are a lot of macrophages coming in to try and get at the organism, the pus. But this organism survives in an anaerobic environment. And the immune cells come in and localize it. It's the same in chronic infections such as TB as well, where you may have a very localized infection. And in the atypical Mycobacterium marinum. And again, this is just a close-up of that localized infection. You can see that a little punch biopsy may miss things here, and you really need a decent incisional biopsy into this. Now, the corollary of this, if you get a localized infection from having a good immune response, what happens if you've got a very poor immune response? Say you're on oral steroids, or say you're immunosuppressed from AIDS, or many of the drugs that are used in treating some of the other chronic diseases like rheumatoid and the like. Then what can happen is you can get systemic spread of this organism, and it can go particularly to the lungs. And this is the case here, where you've got these 2 cavities at the top of the lobes of the lungs on both sides here. And this patient will have a chronic cough, may or may not be productive, but they may not have any or very little in the way of skin manifestations. The organism may have got into the bloodstream. So you have to consider this infection in anyone who's immunosuppressed as well. So let's go back. How would you treat this particular patient? What would you give the patient? Well, one option is to give the patient an old-fashioned drug called potassium iodide, a saturated solution of potassium iodide. And with this, you give it as, maybe 10 drops 3 times a day in orange juice. You actually should start probably less than that. Start with 3 or 4 drops, gradually increase by a drop a day, so that you start with, say, 4 drops 3 times a day, then 5 drops 3 times a day, then build it to 10 drops 3 times a day, and gradually build it until the patient gets features of iodidism, and that's basically when they get a funny taste in the back of their mouth. And what happens is there seems to be well, we really don't know how this drug works, but it will have a very beneficial effect on this condition, but you may need to take it for a couple of months. It seems as if free iodine is released in the tissues, and this inhibits the growth of the organism. The other thing that's curious about this organism is it's very thermolabile, and one of the old treatments was in fact to stick your hand in the hot water up to say 42, 43 degrees centigrade, and leave it there for 10 minutes or so. You've obviously got to watch you don't burn yourself, but at that temperature it inhibits the growth of this organism, and if that's done twice daily, then over a month to 2 months you may in fact inhibit the growth of this organism and allow your immune system to get rid of it. But it's a curious organism altogether. Nowadays, though, the drug that we have that's very effective is a drug called itraconazole. Now, this is one of the azole type drugs. It is usually given as a continuous medication. It's available in Australia for deep fungal infections on our PBS, so it's subsidized, but otherwise it's quite expensive. But again, it has to be given over a period of 1 to 2 months to make sure that you've completely cleared this particular deep fungal infection. So this, as I say, is a very interesting organism with an interesting history when you think back on Benjamin Schenk. You'll see it more in the country, you'll see it in gardeners, you'll see it in people who work in the horticultural industry, you'll see it in people who work in the forestry industry, because these are the sources of this particular deep fungus. So, sporotrichosis, a deep fungal infection following a penetrating injury of the skin, classically from a rose thorn, also from any rotten wood or peat moss. And in fact, the last epidemic we had here was when we had a very warm, wet summer, and a lot of old peat moss had been left out, or peat straw it was, had been left out in a gardening centre, and suddenly a whole lot of gardeners who had bought the stuff all came in with sporotrichosis. The classic feature, an area, a lesion, that penetrating injury lesion that doesn't heal, and then other lesions appear going up the lymphatics. This lymphatic spread is classic of this condition, and the other thing that you think about, if you ever see it, is an atypical mycobacterium infection, Mycobacterium marinum, which is seen in someone who has a fish tank, and they've grazed their finger, their hand, or the back of their hand or their finger when they've been cleaning out the fish tank, and the atypical mycobacterium organisms got in, and it will sort of show this type of what's called sporotrichoid spread or lymphatic spread as well. So those two conditions to think of, but sporotrichosis if they're gardeners. So I hope you've enjoyed this sojourn into the injury that spreads. Thank you very much.